Hello and welcome everyone. Thank you for joining us today for the 2021 Healthcare Purchasing News Healthcare Professionals Industry Forum. My name is Ebony Smith, Managing Editor for HPN. I'm excited to have with me here David St. Clair, Executive Chairman at halosol International, and Deborah Runyan, former Director of Infection Prevention at Pennsylvania Hospital. They will be discussing a critical topic: eliminating pathogens in healthcare settings, including how to evaluate the efficacy, flexibility, and usability of different disinfectants, and delivery methods against deadly and emerging pathogens. David has served as the Executive Chairman at halosol International since 2008. Prior to joining halosol, he acted as the founder, director, chairman, and CEO of Medicision. David served for 30 years on the board of the Center for Autism as a director and chair of the Strategic Planning Committee. Deborah served as the Director of Infection Prevention at Pennsylvania Hospital until her retirement in 2020. In 2011, Deborah received the APIC Hero of Infection Prevention designation for her work implementing a securement device for peripheral IVs. In 2015, Deborah presented strategies in reducing C. difficile to the International Congress of Epidemiology and Public Health in Mexico. Today, David and Deborah will go over disinfection practices in healthcare, including identifying a true whole room disinfection system, selecting an EPA-registered disinfectant with a 6-log kill claim against emerging and hard-to-kill pathogens, and strategies created to combat the spread of C. difficile in the University of Pennsylvania health system. So David, let's get started with today's presentation.
Thanks, Ebony, for the introduction. As Ebony said, we have Deb Runyan here with us. Deb was the leader of the infection prevention effort at Pennsylvania Hospital in Philly for many years. And Deb will give us some insight into their challenges and successes later in this session. Mary Alice also will be on the chat line if you have questions during this first session. Now, as all of you know, by its very nature, working in environments that are at high risk to contain contagious pathogens, the healthcare industry, broadly defined, has been at the forefront of disinfection and sanitization. In particular, facilities prioritize the prevention of healthcare-associated infections, HAIs. Yet still, 1 in every 31 hospital patients has at least one HAI during their stay. Now, the common pathogens that cause HAIs are included in this box. Although healthcare facilities have been on the cutting edge of disinfection standards, the emergence of COVID-19 this past year has led to an increased emphasis on disinfection, not only in healthcare, but really across industries. Increased concerns regarding disinfecting environments exposed to the SARS-CoV-2 virus, as well as other deadly pathogens, has challenged even the most diligent facilities and organizations to reevaluate their disinfection strategies. One of the approaches that they've really focused on is this whole notion of whole room disinfection that ensures no pathogens slip through the cracks. Now, what is whole room disinfection? It's a technology that can truly disinfect all exposed surfaces, including nooks and crannies, in an often complicated space. Think of operating rooms, think of patient rooms. And while there are many application methods for disinfectants, there are really very few of them that are true methods of whole room disinfection. If we go through some of the different, or 4 of the major ways of applying disinfectants, spray and wipe clearly is the most common, and it's easy to use and relatively inexpensive, and it can be used when other people are around. The disadvantages for spray and wipe are that surfaces must be thoroughly wetted for the contact time of the disinfectant. And regardless of the type of disinfectant being used, the efficacy, the reduction of bioload, is widely reported to be under 50% in most rooms. So as a process, spray and wipe clearly doesn't begin to meet the definition of whole room disinfection. Electrostatic sprayers have become increasingly popular And they're a really good replacement for the old spray bottles for use in certain circumstances. Now, electrostatic sprayers have become particularly popular since COVID-19 began, particularly in non-healthcare settings like schools and transit systems. But the improvements in dispensing and efficiency still depend on wetting all surfaces, and overspray can have harmful effects on electronics and create material compatibility issues. In addition, staff has to wear full PPE because of the airborne disinfectants. Now, as we're all well aware, very expensive UV lights have been purchased by many institutions over the past few years in an attempt to help reduce HAIs. Problem is, UV light cannot reach pathogens in shadowed areas and has a lower kill rate than chemical disinfectants. Materials close to the light source will be over-radiated if you're trying to kill pathogens in the far corner of a room. But if sanitizing is sufficient, UV lights seldom reach disinfection thresholds in real life. UV lights are an alternative, albeit an expensive one. As a result, UV systems really cannot act as the only disinfection protocol in a hospital or other healthcare facility. Now we get to dry fog. The principal advantages of dry fog is in its name. It doesn't wet surfaces at all. It's safe to use around electronics of all types, and compatibility with most materials is excellent. They're ideal for reducing HAIs in treating areas where an infected individual was known to be. And disinfecting high-risk environments such as the operating rooms and certain other treatment areas is also a common area where dry fog disinfection is used. Now, it's important to be aware that foggers in quotes, that wet surfaces are not dry mist foggers with whole room kill claims. Only dry mist systems that do not wet surfaces have EPA registered whole room kill claims. In short, dry fog is effective for whole room disinfection in a higher risk environment. The three alternative methods with shorter application times can be used in other less risky areas or areas that really can't be isolated. Dry fog is one of the only methods of true whole room disinfection. Now, this is an example of a system dispensing a dry fog in an examining room. All of the surfaces in this room, and you'll note the shadowed areas and materials that really shouldn't be wetted. All of those surfaces will be disinfected to a sporicidal level. Just imagine trying to get to that efficacy in this room with sprays or UV systems. Now, let me turn this over to Deb to say a few words about what her team at Pennsylvania Hospital thought about when choosing which disinfection method to use when their C. diff infection rates spiked a few years ago. Deb?
Hi, sure. So we installed computers over a series of several months in preparation for the electronic medical record, and this is back in 2011, and almost instantly noticed an increase in the number of cases of C. diff. And the only difference was the installation of those terminals. So we suspected that that was the cause. Realizing that we had done very little prep in terms of education and how to clean, especially the keyboards, which had an infinite amount of surface area. Looking at the spray and wipe and EVS performing that task, it's wet and it was prone to a lot of user error, including forgetfulness. The electrostatic sprayer, the same thing, wet delivery would damage the keyboards. UV lights were just too expensive, and even if we could manage to acquire them, all the shadowing issues were a concern for the keyboard. So halosol seemed to be the perfect solution, and no damage to the keyboard. It was going to touch all surfaces, and it was far less subject to human error. David?
Thank you, Deb. When selecting a disinfectant, it's important to ensure that you're in fact purchasing a disinfectant and not a sanitizer and not a cleaner. Each of those have their roles in a hospital environment. So for instance, all surfaces have to be cleaned of what is referred to as gross filth before they can be sanitized or disinfected. But disinfectants require an EPA registration. And you'll see that there are real advantages to knowing that the efficacy and safety of these products have in fact been tested appropriately. Now, what you're going to look for on the bottle is an EPA registration number, not what is called an entity number, but an EPA registration number. Here you have the EPA registration number for Halomist. That's a very common sort of format. And on the labels, you will see that these products have a 6-log kill claim against C. diff when fogged, and a number of other details, including how to actually use the product for different kinds of pathogens and for different kinds of environments. Now, in this past year or so, obviously, we've been very concerned with the SARS-CoV-2 virus that causes COVID, and the Candida auris has made inroads into many hospitals and many long-term care facilities. If you want to kill the SARS-CoV-2 virus, you really want to look at the EPA list N, as it's called. You can Google that to see what products have been approved to kill COVID-19, even if they haven't been tested on that. Similarly, for Candida auris, they have a EPA list K, which normally is the list that they use for products that have been approved to kill C. difficile spores, but they have decided that they also can kill Candida auris after tests of one sort or another. Now, there's a continuum that sort of fits into that of pathogens based on their susceptibility to disinfectants. At those that are most susceptible to disinfectants, those that are easiest to kill, you have envelope viruses, and they happen to include the SARS-CoV-2 virus that causes COVID. So those are the easiest things to kill. On the other end of the spectrum, you have C. diff spores, the hardest things to kill. And the CDC and the EPA essentially have said, if you can kill spores, for instance, you likely can kill everything to the left of that. So their authorization for use against the SARS-CoV-2 virus and Candida auris and things of that nature really is based on how disinfectants operate against this continuum. I'm going to ask Deb to go ahead and tell us a bit about Pennsylvania Hospital and the success that they've had using the dry fog approach over the last decade or so. Deb?
Yeah, so as we stated earlier, the computers created quite a challenge now that there was one in every patient room. We decided to be the beta site for Halomist and see if we could actually operationalize its usage and hopefully in a few months start seeing a decrease in our number of cases. We started with fogging the C. diff rooms, whether a patient was transferred or discharged, that room was fogged, and quickly realized that we had the ability to fog up to 100 rooms a month. So that was our goal. So anytime a room was unoccupied or next to a C. diff room that had been vacated, the room was fogged. We also expanded that to any patients that were seen in the emergency room with C. diff. And as time went on, realized that we could do the operating rooms as well. So we did an operating room every month. We had hoped that it could be more, but that was what we were limited to. And as you can see, our results were very dramatic. In the first few months, we went from a rate of 6.3 to 4.5 cases per 10,000 patient days. And over the next 18 months, got that rate down to 2.2, which was over a 66-point a 66% reduction. We did have some glitches along the way in trying to operationalize it. Of course, we had to make EVS our partner, and they truly were. They were all in, figuring out how to get the equipment where it needed to be, how to identify the rooms that needed to be fogged. Initially, we were just keeping paper logs, which we quickly learned was not quick enough for us to get the information and feedback to them when a room was missed. So all that information was put on a public drive. We sent daily reports to EVS. Yay, if you got 100% of the rooms, and letting them know when a room was missed. We had over 90% compliance after the first few months. Creating a high alert list if a room was missed for some reason, that it was fogged at the next opportunity. Obviously we've used this system for 10 years now. You can see the rates when we first started. We were 4.6 per 10,000 patients and came down to 2.7. And honing the system, we were down to 1.4. Realizing that these rates were in play before NHSN, CDC had a benchmark for rates for C. diff. The lab ID SIR standardized infection ratio wasn't until 2015. So from the time we started collecting data in 2015, our SIR was 0.77, and it was down to 0.5 in 2019. And over time, that rate was statistically significant over and over. And the longer period of time, the more significant it was.
Sure. Terrific. Thank you, Deb.
Sure.
And thank you all out there for listening. And if you have questions, please send them to us. My email is there on the screen, and we look forward to hearing from you. And good luck. Be safe out there.
That wraps up our presentation today. David and Deborah, it has been great speaking with you. Thanks so much for sharing this information with us. On behalf of halosol International and HPN, thank you everyone for logging on to watch. Don't miss the next session in this forum. Click the link at the top of your screen to return to your event hub. Bye, and take good care.